it's really great to be here. I've been a huge admirer of the work you've been doing in philosophy and medicine here, and it's been great to read up on some of the research you're doing. So hopefully you'll be interested in some of the work that I got up to over the past few years, just before the pandemic, where I was working on a Wellcome Trust funded project looking at the ethics of deep brain stimulation in psychiatry. So just to kick off, I wanted to, is it working? If I click it, that's fine. Yeah, just quickly thank my collaborators on that project. I won't read them through because time is slightly short. So the area I want to talk about today is really prompted by the fact that, unfortunately, huge numbers of people today still suffer with intractable psychiatric conditions. So these are resistant to traditional treatment modalities. And that, of course, is a huge issue due to the profound effect that these conditions can have on people's lives. So it's widely accepted that we have a pressing need to try and develop new and effective therapies for these conditions. And in that context, there has been renewed interest in the use of neurosurgical procedures as a potential treatment avenue for these intractable conditions. Now, of course, that is very controversial given the notorious history of neurosurgery in psychiatry. I will very briefly touch on that if time allows. But there's been particular interest in an intervention called deep brain stimulation, which is the main focus of my discussion today. Very briefly, deep brain stimulation involves a neurosurgical procedure in which electrodes are implanted into a patient's brain thought to underlie the individual's psychopathology. Stimulation can then be delivered to those electrodes via a small generator. So this was a topic, as I said, of my Wellcome Trust funded project a few years ago. I began to get quite interested in the regulation of this intervention under the Mental Health Act. And as we know, that's been a very hot topic in recent years. We've had the publication of the independent review a couple of years ago now. But I wrote this paper with my collaborators during that project, looking specifically at DBS in the Act. And we highlighted what we took to be quite an important gap in the law as it still stands, which is that DBS is not really covered by any of the safeguards or other procedures mentioned in that Act, in particular brain lesioning surgeries. This is something that the review has also recognized, and they have proposed making a new treatment category which would include treatments that can only be given with consent at the time. So you wouldn't be able to give them to patients on the basis of an advanced decision, and you wouldn't be able to provide them without consent in emergency use. And the review suggests that government should consult on which treatment should be included, mentioning both deep brain stimulation and neurosurgery for mental disorder. So that's all to say that this is still very much a hot topic, even though the review has now concluded. Just how should we be looking to regulate deep brain stimulation? And that's really the topic that I want to address today. Brief overview of what I want to try and do. I'm going to explain a little bit more about neurosurgery and neurostimulation in psychiatry. Because time is a little short, I'm really going to rattle through that quite quickly. So it's going to be a whistle-stop tour. I'll then touch a little bit on how they're currently regulated in the Mental Health Act, and hopefully have enough time to go into a little more detail on what I think are the neuroethical considerations we have to address when thinking about their regulation going forward. One final quick preliminary, a lot of discussion following the publication of the review of the Mental Health Act about the implications of the Convention on Rights of Persons with Disabilities and how the Mental Health Act appears to, well, it does permit involuntary treatment of some patients. I'm not going to get into that topic at all today for the simple reason that the Mental Health Act review engaged with that question quite deeply and sought to justify the use of involuntary treatment despite that convention. So really in this talk, I'm taking the Mental Health Act on its own terms, if you like. Okay, so a quick overview of the interventions that I'm really going to be talking about. So the first is neurosurgery for mental disorder, or what sometimes gets called psychosurgery. So this is the definition adopted by Pugh, the selective surgical removal or destruction of nerve pathways for the purposes of influencing behavior, often in regulatory documents and statutes. You see the terminology of neurosurgery for mental disorder. That's the terminology I'm going to use today. But the key aspect of the definition is this idea of removing or destroying nerve pathways or perhaps brain tissue. As I said, very notorious history. of these kinds of procedures. I'm not going to go rushing through that slide now because time is short, but we do, I think, really need to stress this point that there were a lot of deep and abiding ethical problems of the use of psychosurgery in the 20th century. Many procedures carried out in the absence of informed consent on the basis of really deplorable patient selection criteria. So you would have case reports of people bringing misbehaving children in to have very crude neurosurgical procedures, the infamous frontal lobotomy being one. And these, of course, had really devastating negative consequences for the patient. They were carried out on a very crude understanding of the role of the brain in psychopathology and caused lasting damage. So we absolutely have to acknowledge that history, but it's also important to recognize that the kinds of neurosurgery for mental disorder that we think about today are really a quite different set of procedures. Not to mention the fact that they're typically carried out on the basis of robust informed consent procedures. The kinds of technology we employ are far more superior. Each patient is subject to really rigorous functional neuroimaging to determine the correct site for potential brain lesioning. Surgeons use a stereotactic frame to make sure that the patient's brain is held in a very fixed position during the surgery. And that was an intervention that massively increased the safety of neurosurgery in the mid-20th century as well. So that's led to many bodies accepting that neurosurgery for mental disorder can be reasonably considered for some carefully selected patients. It's a quote from the Royal College of Psychiatry. But that's not universally accepted. In fact, there are still a number of jurisdictions that outright prohibit the use of neurosurgery for mental disorder. Now, if you're interested in some of the detail on that, I very much recommend the overview given by Kenneth Barrett in the British Journal of Psychiatry a couple of years ago. Just briefly looking to the future of neurosurgery, destructive neurosurgery at least. One of the big issues, of course, with that surgery is that it involves an intracranial procedure, and that carries quite significant perioperative risks of hemorrhage and the like. But there's been a growing interest in the use of non-invasive brain lesion procedures using ultrasound. And of course, if that is going to be a successful avenue of research, that will hugely change the risk profile of that modality. Okay, so what about neurostimulation in psychiatry? Again, I won't go through the history here, but just to note that it really developed in tandem with the use of destructive brain surgery during the 20th century. It caused public outcry around the same sort of time due to some very controversial studies. If you're interested, I could say a little bit about those in the Q&A. But also in the latter half of the 20th century, we saw the emergence of deep brain stimulation as a potential treatment in movement disorders. Again, I won't go through all the details here, but just interesting that the demise of invasive neurostimulation in psychiatry pretty much preceded the rise of the use of neurostimulation in the treatment of a somatic disorder. So that's really been a pendulum swing, if you like, because we're now seeing deep brain stimulation being increasingly considered again in the treatment of psychiatric disorders. So what does modern deep brain stimulation involve? Well, first, a patient will undergo, again, an intracranial neurosurgical procedure. This frame you can see in the picture is the stereotactic apparatus, which is served to hugely increase the safety profile of all kinds of neurosurgery. The patient is awake during that surgery, and the surgeon is able to precisely target the electrodes using this functional neuroimaging in consultation with the patient during the surgery. The electrodes implanted are then connected to leads implanted beneath the skin, connected to this device here, an implanted pulse generator, or IPG. And this IPG is usually inserted just below the clavicle, and it can be programmed wirelessly to deliver pulses of electric stimulation to the implanted electrodes. And what's really important about that is the physician, in consultation with the patient, can titrate the level of stimulation to the patient's particular needs. So not every patient will get exactly the same level of stimulation, and you can turn the stimulation on and off at the click of a button. It's been a hugely successful treatment modality in Parkinson's disease in particular. As of 2017, one of the leading device makers had statistics suggesting they'd implanted 150,000 patients worldwide. And given the considerable success of the treatment in movement disorders, there has been increasing interest in using deep brain stimulation in the treatment of psychiatric disorders. I'm not going to go into huge amounts of detail about the evidence base here, but just really to note that although there are a number of promising studies, there's also been some cases in which large-scale studies for DBS in psychiatry have failed. So the Broaden trial, which it was hoped might lead to the licensure of DBS in the treatment of depression, failed a futility analysis. So the evidence base is very much mixed at the moment. I think it's fair to say there's certainly a great deal of promise with DBS. We are seeing some promising results in anorexia nervosa, as you can read up on in that Lancet study. OCD, the FDA has granted a humanitarian exemption, but the evidence is by no means clear-cut. So there's still a lot of investigation to be done. I'm going to skip over that. So what should we think about the comparison between DBS and neurosurgery for mental disorder in psychiatry? Well, in both cases, there's a lack of evidence of long-term safety and efficacy. But we do have some awareness of mid-term safety, if you like, because we do have experience using these interventions in movement disorders. So we know something about the perioperative and post-operative risks in the short term, but obviously we don't have long-term experience using these interventions in the treatment of psychiatric disorders. But one benefit that DBS potentially has over neurosurgery mental disorder in this regard is that it is somewhat easier to investigate that kind of treatment using rigorous trial designs, because you can use the electrodes to target different neural areas in the same patient. You can also turn stimulation on and off, and that allows study designers to develop crossover designs using sham controls. So this is kind of a placebo-controlled trial, if you like, for DBS. Much more difficult to get that sort of design for neurosurgery of mental disorders. So there are some obstacles to the kinds of systematic research you might see in DBS. Not insurmountable by any means, but there certainly is a trend to suggest that DBS is going to be easier to do research on. But there are downsides to DBS. It requires long-term maintenance, so patients will have to live with an implanted device for long periods of time. Not only is that quite expensive, there are also risks associated with that long-term maintenance. You can get leads migrating and potential infection. But the big difference that gets widely discussed in the ethical literature is this idea about reversibility. So to a large extent, at least, the effects of deep brain stimulation are, that's just it, dependent on the stimulation. So if you turn the stimulation off, many of the effects are going to abate. Whereas with neurosurgery for mental disorder, once you've destroyed or removed brain tissue, that's it. There's no going back. It doesn't come back. The effects of the treatment are going to remain. So part of what I want to do for the next, 20 minutes or so is really think about the implications of reversibility for how we think about the regulation of these different interventions. Very quickly, just to mention ECT as another kind of treatment used in psychiatry that's also specifically regulated by the Mental Health Act. I won't go into detail given the time restraints, but again, we can talk about that afterwards if that's of interest. So how are these interventions regulated, or perhaps not, as the case may be under the Mental Health Act? Now, I don't want this to become too dry and technical, so I'm going to be talking about the relevant sections of the Act in quite broad strokes rather than just quoting the precise wording of each section. So what I'm trying to do here is get the core of the regulatory approach rather than the precise letter for the purposes of our discussion. So one key section to be aware of in part 4 is section 63, which essentially grounds this idea that clinicians can provide treatment for mental disorder to patients detained under the Act without consent or a second opinion. So treatment for mental disorder given by or under the direction of an approved clinician requires neither consent nor a second opinion, unless one of the following sections applies, 57 to 58A. So that's important because it essentially sets up this default position. You can provide involuntary treatment under the Act. And these sections, 57 to 58A, relate to certain treatments that have further safeguards in place. So they're kind of exceptions to this general default position, if you like. So what are these exceptions saying? Well, let's look at section 57 first. That's important because that section explicitly relates to what I'm calling neurosurgery for mental disorder. So it relates to any surgical operation for destroying brain tissue or the function of brain tissue or other treatments specified by the Secretary of State. And Section 57 puts in place really quite strong safeguards. So in order to carry out a Section 57 treatment, you have to have both consent from the patient and a second opinion certifying not only that the patient is capable of understanding relevant information about treatment, they must also certify that the patient consents and that treatment is appropriate. So you've kind of got a consent safeguard and a beneficence safeguard, if you like. Section 58 treatments have somewhat weaker safeguards. So if the patient consents to treatment and the clinician is certified that they're capable of consenting, then you can provide the 58 treatment without going ahead and getting a second opinion. However, if the patient is unable to consent, if they lack the ability to understand relevant information, you can potentially still provide a Section 58 treatment if you can get a second opinion certifying that the patient lacks consent and that the treatment is appropriate. So it's an either-or situation here. The crucial thing for 58 is that you can give a Section 58 treatment to a patient who lacks capacity. You can't do that with Section 57 in non-urgent circumstances. I've put the relevant section for ECT there, 58A. Again, given time, I'm going to skip over that. We can come back to it at the end if it's of interest. One final point, a general exemption to the exemptions, if you like, is Section 62, which applies to emergency situations. We don't need to get into that detail for what I'm going to discuss today. Again, we can come back to it at the end if it's of interest. So here's the problem, which some of you might have seen. Section 63 gives us this default position that treatment is permissible in the absence of consent unless the treatment in question falls under sections 57 to 58A. Crucially, though, the Secretary of State has not yet specified that deep brain stimulation falls under Section 57. In fact, there are potentially some good reasons for that, which get into a bit of a technical detail about how the current law is worded. That was a topic that we took up in the published paper I screenshotted at the beginning of the talk. Happy to discuss that later. But the general problem I want to talk about in the remainder of the presentation is this fact that while DBS is unlikely to fall within the scope of Section 57 without specific specification by the Secretary of State, the reason being is that it is not a procedure for destroying brain tissue. When you implant electrodes into the brain, you do create what are called micro lesions. So that is technically a kind of brain destruction, but you're not seeking to elicit a therapeutic effect through the creation of those lesions. The therapeutic effect is evinced by the stimulation itself. And in fact, the Care Quality Commission have been quite clear that they don't believe that Section 57 safeguards cover deep brain stimulation. They made this point in a commission document a number of years ago now, in 2009 and 10. So this is a big gap. We know that DBS is a highly experimental treatment. It carries significant perioperative and potentially postoperative risks, and yet it's not subject to any significant safeguards under the Mental Health Act. Now, that might be excusable in the sense that DBS is a highly novel treatment, so perhaps we haven't had enough time to come to terms with it and how it ought to be regulated. But it's notable that the Mental Health Act of England and Wales, at least, is really behind the times here. So many jurisdictions around the world have already explicitly incorporated DBS into the protections governing neurosurgery. In fact, our friends in Scotland did that a number of years ago. Other jurisdictions have in fact drawn up a completely new DBS-specific provisions in updated mental health legislation. If you're interested in the different approaches you could see internationally, I highly recommend this paper on the screenshot by Jennifer Chandler. But here's a very broad overview of the kinds of positions that you can see internationally. So let's think first about the levels of safeguards we might employ. So the first very strong approach you might take is to say we should just simply prohibit deep brain stimulation. We don't know enough about it, and it's too risky. That is one position you might take, the position taken in New South Wales. The issue with that kind of approach, though, is that it potentially prioritizes considerations of non-maleficence at the expense of considerations of beneficence, right? So if you take this highly risk-averse approach, you're potentially going to prevent people from accessing a treatment that later down the line we might establish could be hugely beneficial for patients. So we might have a bit of concern about an outright prohibition, a lot's going to depend upon how we're currently reading the evidence and how amenable our regulation is to change later down the line. The majority position, I would say, looking at the international legislation, though, is to claim that DBS can be used under mental health legislation only if consent is present, only if the patient can consent to treatment. And that's an approach taken in Western Australia. The lowest level of safeguard, if you like, and this is in fact evident in the Scottish legislation, claims that DBS can be used amongst patients who lack capacity. So you don't necessarily need consent to perform DBS in Scotland. That's also true of neurosurgery for mental disorder in Scotland. So these three different levels of safeguard, really it can be viewed as a balance between, striking a balance between non-maleficence and beneficence, and depending on our understanding of the evidence base. Another way to frame the regulatory discussion, though, is to think about the consistency of our position about the protections for DBS with our position on the protections involved with other kinds of interventions we might use in mental health care. So one approach might say, well, look, perhaps we should subject DBS to the same kind of protections as ECT. After all, these are both forms of neurostimulation. We can turn the stimulation on and off. They're both reversible. So perhaps that's enough to say we should treat them in the same kind of way by under a regulatory approach. There were hints towards that kind of view in one of the very early Mental Health Act commissions. I think it was really raised as a suggestion rather than a serious recommendation. But I think there are quite powerful reasons why that wouldn't be the correct approach, namely because DBS involves this intracranial procedure. So it involves significant perioperative and postoperative risks in a way that ECT doesn't. That's not to say that ECT doesn't involve its own risks, but I think those involved in intracranial surgery are really quite significant. So again, the majority view is that DBS should be subject to the same provisions as neurosurgery for mental disorder. Again, a couple of jurisdictions, there are jurisdictions within Canada and Australia that adopt that kind of approach. The final one would be to claim that DBS should be treated as its own special category, if you like. So there are differences between DBS and ECT as well as neurosurgery for mental disorder. That's roughly the position I think the law might gravitate towards as the evidence base develops. But I think at the minute, we should probably be endorsing something like B. And in the next, how long have I got? 10 minutes or so, I'm going to try and give you a flavor of why I think that might be the case. And it really boils down, as you probably guessed, to this point about reversibility. So a couple of years ago, Devon Stow and colleagues wrote a paper arguing that DBS for psychiatric disorders should be considered a form of psychosurgery. One of the big arguments behind that claim was their thought that the reversibility aspect of DBS isn't really a sufficient basis for distinguishing between the two. This is something that I responded to in a different paper. This was published in the Journal of Medical Ethics. So I'm drawing a bit on the arguments in that paper here. So how might you attack this reversibility claim? Well, Stow et al.'s approach is really to bring together evidence of some irreversible effects that have been observed following deep brain stimulation. I've talked already about microlesions involved in electrode insertion. There is also some evidence of glial scarring in some patients. Diane Rouge and colleagues have done some excellent work demonstrating that in patients receiving chronic stimulation in the treatment of movement disorders, there is some evidence of neural reorganization, which has led to the persistence of a clinical effect even when stimulation ceases. So that obviously has quite profound effects when we think about the application of DBS in psychiatry. Also, and this wasn't mentioned in Stow et al.'s paper, but there are rare cases in which there have been non-stimulation dependent effects that have been observed in patients, which were really quite unexpected. This was a study I was tangentially involved in a few years ago with colleagues in Oxford, which was looking at a case in which a couple of patients who are receiving deep brain stimulation for the treatment of chronic pain began to develop epileptic seizures, essentially. And in fact, two of those patients developed de novo epilepsy, so a brand new medical condition, even when the stimulation ceased. So, of course, it's hugely problematic. Frederick Gilbert has also done some work looking at non-stimulation dependent effects of DBS in the treatment of depression. And there are some suggesting that some patients can come to feel a quite profound level of self-estrangement. Again, we can discuss that a little further afterwards. So that might make you think, well, this idea that DBS is reversible is really dead in the water, because we clearly have evidence that DBS can lead to some irreversible effects. I think that's a bit of a quick conclusion to draw, though. So I think what this evidence requires us to do is really revise the descriptive element of the reversibility claim, if you like. So we should avoid the claim that reversibility is simply a binary matter. Either an intervention is reversible or it's not. Really, the reality is that in any medical intervention, some features might be reversible, some features might not be, and in fact, some we might really not be certain about. So the relevant question isn't the simply descriptive one, is a intervention reversible or not? Really, we have to ask a more evaluatively laden question. We have to ask which features of DBS are irreversible, why do they matter, and which features of DBS are reversible, and why do they matter? And crucially, when you look at some of the irreversible effects, it's not clear how much they're going to matter morally necessarily. Of course, when we look at the rare cases, as I demonstrated in the chronic pain example, there can be really quite profound irreversible effects. And of course, they matter hugely, but they are quite isolated cases. The kinds of effects that Stahl all drawing attention to, such as microlesioning, occur in pretty much all patients who receive DBS. But we've got quite a lot of evidence from the use of DBS in the treatment of movement disorders to suggest that microlesions alone don't really have significant implications for patient well-being or the treatment trajectory. So it's really important to ask this evaluative question. And to wrap up the discussion, I want to just draw attention to why the fact that many features of DBS are stimulation dependent is so important from the neuroethical perspective, if you like. The first reason is simply that the duration of a harm matters for well-being. That's a basic point about the nature of well-being. So if we have a medical intervention which unfortunately leads to side effects or unexpected complications, then it's hugely important whether those side effects and complications are temporary or permanent. The reason being that the longer a harm occurs, the worse it is going to be for you. So that's a really quite basic point, but it's an important one to acknowledge, because in both neurosurgery for mental disorder and deep brain stimulation, unfortunately, we do get cases where patients aren't entirely happy with the results of treatment. So it can be really important that they can switch that back. And that's also related to another ethical aspect about the importance of reversibility. That relates to autonomy. Again, I am rushing through this quite quickly, I acknowledge, and this is very much a rough and ready definition of autonomy. But you might view autonomy as something like the ability to make informed choices on the basis of your own values and preferences, and to some extent, having those choices realized. Now, one important thing when we think about treatments in psychiatric context, particularly for intractable conditions, is that ameliorating those conditions can be an example of what Laurie Paul has called a transformative experience. So Paul has this book on the phenomenon where she identifies transformative experiences as those that are radically new to the agent and which change her in a fundamental way. And that's important because on Paul's approach, agents lack epistemic access to what it will be like to undergo that experience. So I think the example she uses in the book is we couldn't have an idea of what it would be like to turn into a vampire overnight. That's a frivolous example, but when you think about people who have been living with serious intractable conditions for a very long time, particularly those that are deeply ingrained into their own sense of identity, in the case of ego-symptomic disorders, I think there is a good case to be made that effective treatments, especially those that work on a very quick basis, potentially like DBS and neurosurgery for mental disorder, could have quite disruptive effects. And in fact, we do actually see that when we look at the patient interview studies. So this has been observed both in the context of Parkinson's disease and also more recently in the context of DBS for obsessive compulsive disorder. Patients can often report they feel like a completely new person following DBS treatment. Now, there's been a lot of debate in the neuroethics literature about what precisely that means and whether DBS is in any way directly inducing changes to personality. That's not a story I particularly buy, but it's widely debated. But whatever we think about the causal mechanism for that phenomenon, it's certainly true that patients do experience this quite significant disruption. So what implications does that have for reversibility and autonomy? Well, the first thing, just to reiterate again, is it can be important not just for well-being, but also autonomy, that we're able to avoid unforeseen side effects, that we can reverse them. Because it's simply a way of avoiding the frustration of autonomous preferences. But with respect to the transformative experience point, DBS does quite well here, I think, because it enables a patient to get epistemic access to what it's going to be like to undergo an effective treatment, both positive and negative, without permanently committing them to that state of being. And that's also important because when we think about the mode of intervention in deep brain stimulation, it's going to require patient involvement along a treatment trajectory. So it's not just the case that you go in and get your neurosurgical procedure and never see your clinical team again. Rather, you're going to be making a lot of repeat consultations to titrate your stimulation to the needs of your condition as it progresses. So I've managed to do that in just about the allotted time. So here are some conclusions we can draw. Certainly a mistake to say that DBS is reversible simpliciter, but I think it can be reversible in ways that may plausibly have legal significance, particularly given their implications for autonomy and well-being. The remaining question, though, is just how much influence should that reversibility have in this discussion of the safeguards that are appropriate in mental health legislation. Now, this very, very quickly is a model that I haven't published on at all, but it's one that I will be working on, I think, in my new work in this area. And just very briefly to describe it, we can imagine, if you like, a spectrum of, on this end, from high expected harm and low benefit, right to the other end of high expected benefit to low harm. And we can place any psychiatric intervention, and indeed any medical treatment, somewhere along that spectrum. And what we might want to do when we think about regulating medical interventions is set certain thresholds along that spectrum. So the first threshold we might put in place is a prohibition threshold. So we might say that any intervention that poses a high enough expected harm or promises a low enough benefit, we should simply prevent patients from accessing them. We shouldn't use them. As we've seen, New South Wales has taken that kind of approach to DBS. So perhaps they think DBS is somewhere this end of the spectrum. On the other end of the scale, you might want to set a threshold towards the polar opposite extreme, whereby if an intervention falls over that threshold, then perhaps it should be permitted in patients who lack the capacity to consent to treatment. So in a lot of jurisdictions, but in Scotland, England, and Wales, ECT will be put at this far end of the spectrum. Right? We can provide ECT for patients lacking capacity. The really difficult part is this corridor in the middle. And the approach we take in the current Mental Health Act is to put what we might call a consent necessity threshold. This is essentially section 57, where we're essentially saying, look, we think there is some benefit to this treatment, but the risks are still significant. So we're only going to let people be exposed to those risks if they have the capacity to consent, if they have the capacity to waive their rights against those potential risks. So if we think DBS falls into this orange area, then the consent necessity threshold is the one to employ. Now, for what it's worth, I think that's where we are at the minute, given the state of the evidence base. And that's something that people can reasonably disagree upon. My thought, though, is that as the science progresses, it could be that we come to expect a higher expected benefit from DBS and indeed of neurosurgery for mental disorder. But I think there's certainly room in this grey area, if you like, for making a consent requirement contingent on irreversibility. And the justification for that is that when considerations of non-maleficence and beneficence aren't giving you a clear steer, considerations of autonomy and particularly of facilitating autonomous decision-making is really going to be crucial to the ethics and regulation of the intervention. I acknowledge that this was really a whistle-stop tour of that. I had a 45-minute talk leading up to that. I've hopefully squeezed it into half an hour, so I'm sure you've got loads of questions. I think I have some questions about how I've just phrased that. But yeah, hopefully that's enough to get us going. Thank you so much for listening.
Well, thank you, Jonathan. That's an extremely admirable job of squeezing a 45-minute talk in 35 minutes. So the way this is going to work is we have a Q&A. People in the chat are welcome to either, actually the easiest thing is if you can type into the chat. If you have a question, you can just put a Q in the chat and then I can call on you and you can ask your question in person. Or if you don't want to ask a question in person, you can just type your entire question into the chat and then I will read it out. And people in the room can just raise their hand the old-fashioned way and anonymously. Please go ahead.
Thank you. Yeah, it's a really interesting talk, very interesting topic. And I was thinking a lot about the way in which there's specific provision within the mental health act for ECT, and how that's always struck me as slightly kind of bizarre, actually. And to some extent, I think part of that's the historical connection with things like psychiatry, rather than really any actual assessment of risks and benefits. There are lots of treatments we're aware of that are drugs that are far less reversible actually than the effects of ECT. I also think about things like anti-TMS, which actually have a kind of comparable method of working that actually don't seem to be covered in the same way. And I suppose I was just thinking about the difficulty we have when trying to implement these things in kind of practical, pragmatic, legal framework, because it seems that actually, I think that the kind of public perception plays such a huge role in our understanding about how these things should be regulated, rather than really these kind of rational considerations. And then, I suppose when I was thinking about the kind of DBS effects as well, I suppose I was thinking that so much of this is dependent, not just, when I was looking at the kind of the model that you're using. I suppose the thing that maybe I was thinking about were also the assumptions we have about those things when we don't know. So with medications, I think there's often this assumption that actually, perhaps when we have a greater degree of uncertainty, we skew it towards the right. Actually, when it comes to something like surgery, we skew to the left. Yeah, absolutely. And I think that's just so interesting how you operate, how you kind of try and generate a law that reflects that. I think quite a lot of the time we end up being skewed by what the public thinks. And I think actually the Mental Health Act probably, in many ways to me, is probably a bit of legislation that reflects a lot of public fear, specifically around issues of, loss of identity, of treatments, of interventions that affect that particular part of ourselves, that affect our ability to be autonomous. I don't know, I just wonder.
Yeah, no, that's
Sorry, I'm just checking that people on Zoom didn't hear all of those questions. So could you try and answer in a way that either summarizes or makes clear the question is?
Well, it's an extremely rich question, so I'll do my best. The rough kind of thrust of it was some of the parts of the talk I didn't really get into much detail on was how ECT is regulated under the Mental Health Act. And sorry, what was your name?
So
Isaac. And Isaac was pointing out that in some ways that's quite an odd feature of the Act, because we've got a lot of evidence about the potentially irreversible effects of traditional medications, and these aren't specifically regulated. So why do we have these very stringent kinds of protections for things like ECT, and then moving to DBS and neurosurgery? It isn't necessarily that we rationally regulate in some ways by looking at the risks and benefits. There's a lot of public perception about all of these interventions, and in fact, when we think about the risks and benefits of traditional medications, we'll tend to, in cases of uncertainty, skew more towards believing they're going to probably benefit the patient, whereas with novel neurosurgeries and invasive procedures, we skew towards a more precautionary approach that they may well harm people. Is that about right? Yeah. So really, I agree with all of that. So it's a very easy answer. And like I said, I didn't get time to look at ECT, but I think you're right there. The public perception of ECT has really played a huge role. I mean, the provisions for that only came in 2007, I believe, right? So it was a recent development. It's going to be very interesting to see what they do following the review, because in this new treatment category, they very explicitly said, look, we want to look at DBS and neurosurgery here. And the 2007 revision said we're only going to allow ECT for patients under 18 with consent, and that was conspicuously absent. So yeah, I don't know how that's going to go, but yeah, I think like I said, the notorious history of all of these different kinds of interventions is undoubtedly playing a role. I really like the point as well that we might take a more precautionary approach for surgery than we do with other kinds of interventions. Again, that's probably an artifact of these sociological aspects, right? So yeah, I don't have a good answer beyond really agreeing with you. So thanks for the observations.
Rivka.
Hi, thanks, Tony. And that was pretty interesting. I'm following on this question, I think, because as you know, I think you make a lot of really valid points about which ethical principles we need to consider. But what I found interesting, at no point was there reference to maybe the service users are kind of inclined to think about DBS specifically, or any of these other kind of potentially sociological, controversial interventions based on sociological factors. And it strikes me that if we're talking about risk and harm, we need to think risk and harm in terms of what content. When patient values and service user campaigns or whatever other representation they might have, which I know are harder to find in psychiatric spheres than others, what are they saying? So I'm asking both an empirical question and a question about the integration of this.
Absolutely. So I can't go back on the slides, but so to repeat for the people online, Rivka was asking, what should we make of patient perceptions on treatment when we're thinking about regulation? So I was speaking the talk really about the risks and medical benefits of the treatment, but of course, patients will have their own perceptions on what things like deep brain stimulation and neurosurgery mean for them, and how should that be fed into regulation. Again, great question. And the answer to it, I think, is, of course, we have to listen to patient preferences and address any fears they might have. One of the slides I put up, which I didn't have enough time to go into, are these patient interview studies. So what we're beginning to see a lot more of now, thankfully, is following these big, large-scale trials, which don't always occur within the remit of the Mental Health Act or anything like that. So you're getting patients who are consenting to be part of a trial because they want a chance at accessing a treatment they believe has got a good chance of benefiting them. We're seeing much more detailed analysis of what patients' own perspectives on the treatment are after the fact. That's leading us to recognize there are potentially some benefits of treatment we didn't foresee. So if you're interested in that, Sanika Dahan's paper that I screenshotted, perhaps I can send the slides around after this, is really, I think, a tour de force article in that, because it really goes into a lot of deep detail, not just into the patients' views themselves, but how they link to our conceptions of different kinds of risks and harm. So absolutely, we need to regulate in a way that is completely sensitive to patient perspectives. I think it's also important that when we're talking about the technology, we need to be very clear in our communication, because it's the sort of intervention that can be misunderstood. And there are, of course, a lot of very well-grounded fears given the history of the intervention. So we need to address concerns and we need to listen to patients, but we also need to regulate soon, because these interventions, as I mentioned, aren't currently well governed at the minute, I believe, in England, Wales, and we need to follow suit of the countries that are putting some safeguards in place. That might speak in favour of a precautionary approach until we know more about what patients think. Yeah, that seems to me a good approach.
Sorry to hear. Oh, Archie, yeah. Sorry.
So there are a lot of things that you can do to another person without their consent, especially in medicine. So psychiatry off the bat is a weird space as far as consent is concerned. When you drew out your spectrum of, it seemed like it's an axis of risk-benefit ratio, right? The risk-benefit ratio goes up, you're less likely to consent. That sounds weird. If you then let's say you add another axis, which is reversibility, from one-dimensional to two-dimensional space, I still don't see how consent has anything to do with this space, right? So unless you believe that it is impossible to evaluate benefit without that person themselves telling you whether or not it's beneficial to them, in which case you should need consent everywhere in the space, or you're making some objective evaluation of benefit, in which case no consent is needed anywhere. Right? So consent, I don't see why it's on this spectrum at all.
Yep, that's a fair question. So the first thing to say is that at the beginning of the talk, I mentioned that I'm taking the Mental Health Act on its own terms. And I personally have a lot of problems with how consent should the Mental Health Act, but so I totally accept that point. But taking it as it is, I think the idea of these section 57 to 58A aims to capture this idea that, look, perhaps there are some treatments, interventions that pose much greater degrees of risk than others. And even if we think it's okay to give certain well-studied medications to patients without consent, maybe we want more stringent safeguards for riskier procedures. I think that's the general shape. I agree with your point here. We maybe have really miscategorized a lot of things here. So why are we focusing on ECT and not all these medications? Absolutely, point taken. But I think the general shape, the general idea that, look, if you have really risky interventions, we might want to have a consent requirement, even if we don't require consent across the board. I think I can make sense of that. I suppose one angle of what I'm getting at with this sort of spectrum idea and why reversibility matters is because I think there are two ways in which your considerations of autonomy can come in here, right? So, of course, respect for autonomy plays a really crucial role in underpinning informed consent procedures, right? So my way of conceptualizing the role of informed consent procedures is basically it's a way in which people can choose to waive their rights against medical intervention, right? So I've got a right to bodily integrity. It would be wrong for a doctor to come and perform an intervention without me saying, okay, I'm going to waive that right. Please give me the treatment. So that's one very important way that autonomy plays a role, but it's kind of a role in conjunction with these rights, like this right to bodily integrity. A quite different role that autonomy is potentially playing here, and kind of further up the spectrum, as I suggested, is this idea that, look, when we're making autonomous decisions, we need to have sufficient understanding of what we're doing. Now, when we're talking about consent at the other stage, we might be consenting on the basis of some uncertainty, but we can still have valid consent even though we don't have complete certainty about the outcomes of treatment. But the more information we have, the more autonomous we are with respect to our decision making. So this is a point where I think consent and autonomy do start to come apart, because you can have a degree of understanding that's sufficient for valid consent, but which isn't necessarily full-blooded autonomy, if you like. So the idea about reversibility is that, look, even if you don't think the risks are sufficient to require consent, you might think that reversibility matters when you're deciding about the safeguards that are appropriate. Because if you have a patient who lacks capacity, you might be able to facilitate their ability to make a future autonomous decision about whether the treatment is right for them. Whereas with an irreversible procedure, once you've given it, the patient doesn't have an opportunity to exercise autonomous choice then. The deal is done, if you like. So that's the kind of rough idea. Does that answer the question?
Yeah, could I follow with that?
Yeah.
So there is a parallel, right? So if someone is hit by a car, there are also some irreversible things you can do with that, right? You have bits of dead gut, different stomach, cut off the leg. And none of this is reversible. It's all supposedly, well, maybe I don't say technically kosher, but like it's all equal. So see, in this case, right, let's for a moment say that we don't agree that ECT and drugs are different kind. They all just sit in this space. Then the question again boils down to risk benefit.
Yeah.
So you would do something irreversible if the risk benefit was high enough.
Yeah, so
Or
I
at
think
least you would in the surgical case, right? So again, adding reversibility.
so. Yeah, I think I
What
see.
is that add? What do you add?
Yeah, so I guess another way of viewing it is that it comes to this point about harm and well-being again. So if you have an irreversible intervention, then any harm associated with that is going to be much, much worse than a reversible intervention. So purely in terms of risk benefit, typically an irreversible procedure and will be kind of further this way than a reversible procedure, unless the type of benefit is very different. So that's kind of one way of addressing the point. And there's still this thought, I think, which is relating to autonomy, right? So when you can reverse a procedure, in some sense, it's going to be easier to justify for a patient who isn't able to make a decision right now, but can make it later, because you're giving them the opportunity for autonomous choice, which would be absent if the intervention was irreversible. So, you can conceptualize that as a kind of harm as well. So yeah, in that sense, I do agree with you. One thing, again, I didn't get a chance to go into in detail here, is that you have this section 62 of the Mental Health Act, which outlines these, the current Mental Health Act, which outlines these emergency use circumstances where sections 57 to 58A don't apply. One of the interesting aspects of that is reversibility comes in there. So it's on the slide, let's see if I can remember the correct wording. You can use any intervention when it's immediately necessary to save life without consent or second opinion. That would technically include neurosurgery for mental disorder. But you can only use reversible interventions when that's necessary to prevent serious deterioration. So the law itself is already saying, look, reversibility is kind of a way of reducing expected harm. So it's kind of in the law already. What it isn't doing, though, is playing any role in when or whether consent might be necessary in non-urgent circumstances. The point of the spectrum is to say, look, I think we're taking the right approach right now because the evidence is so uncertain. But if we get much better evidence of safety and efficacy, we might be in this slightly more grey area. So I suppose that's the kind of the approach.
Oh, that's a question in the chat. Paul Fletcher. Please unmute.
Okay. Fascinating talk. I've really enjoyed it. I'm not familiar with the area, but I'd just like to ask a question about the difference between side effects and reversible and irreversible effects. Can you actually, how do you decipher between a side effect and something that is irreversible? And obviously with side effects, I presume you could alter the stimulation to reduce some of that in some way. And where does the law sit on you actually making that decision between a reversible and irreversible effect? I think you've just answered that, but I'm interested in the deciphering between a side effect and an irreversible effect. If you could just expand on that a little, please.
Yeah, it's a great question. And the first thing to say is, I think really the law is very unclear about this. So the only reference you get to reversibility in the Mental Health Act is, as I just mentioned, in section 62, where they say, look, there are some things you can do with reversible treatments that you can't do if they're not reversible, but it doesn't give a definition of reversibility. That was partly why I wrote this paper, which I screenshotted in the slides, about what is reversibility in deep brain stimulation? Why does it matter? So it might be perhaps interesting in you in that regard. But what I take it to mean is, in the context of deep brain stimulation, is the effect of treatment dependent on the stimulation itself? So we can turn the stimulation in a DBS system on and off almost at the click of a button. And in many cases, that will cease the therapeutic effect, or indeed the side effect. Unfortunately, we are seeing in some cases people undergoing DBS who develop these non-stimulation dependent effects. So when you switch off the stimulation, the effect persists. So that's what happened with these chronic pain patients, unfortunately. They developed de novo epilepsy. To give a really sort of stark example of the reversibility, this was a case I had in the longer version of the talk, again, very widely discussed in the literature by a Dutch group, I think, led by the authors Link Genes. In this case, you had a patient who was undergoing deep brain stimulation for Parkinson's disease, and he had a very severe motor impairment. And fortunately, the stimulation managed to really significantly improve his condition. So he was really able to move independently again. Unfortunately, though, they found that when the stimulation continued, he developed a completely manic state, a really severe manic state. So much so that under that state, he had to be committed to a psychiatric institution. However, when they stopped stimulation, he returned to a non-manic state, but the motor impairment returned. And so the patient was essentially given this choice. He could either choose to continue with treatment, and he would be able to move independently, but he would have to live the rest of his life in a psychiatric institution due to the severe mania. Or he could choose to completely stop the treatment, live in society, but unable to move independently, essentially. And interestingly enough, the patient would choose to continue treatment. So he continued the treatment and life in the psychiatric institution. So that's how profound, the reversibility of DBS can be. So yeah, that's a kind of overview, but hopefully gives you a flavor of some of the relevant aspects.
Is it okay if I ask a question? I mean, it's just actually partially related to this final example is a nice one, right? So you refer to the work on transformative experience, right? And as probably many of us know, but I've thought about transformative experience. Transformative experiences are going where we don't have epistemic access to what it's like. And crucially, also in the transformed state, it's your values often that change themselves. So the thing to become a vampire, it's not just that like, you can live a knife and stuff, but like you have a desire for blood, and which you all don't have. Other examples, parenthood is a transformative experience. So in these kind of cases, last one's kind of good place. If we take seriously that transformative experience is like an element here, where we can't access what it's like and indeed what we value under the conditions of brain stimulation, or brain stimulation, which, the thing arguably goes both ways. So the kind of example you just gave, who do we know? How do we know who to ask, when to ask, what should be? Should that be the person with or without brain stimulation? Now, in this case, I mean, if a person was manic, maybe they're automatically declared as not having capacity in a manic state. So you've got to ask the person with Parkinson's disease. But in some of these like brains, how do we deal with those aspects of autonomous decision making?
I was really hoping not to get into this. It's hugely complicated, but this is really the question that motivated the project to a large extent. It was like originally in this field started looking at the use of DBS in anorexia nervosa. And that's, of course, hugely complex, right? You have patients who, any patient involved in a DBS study for anorexia has capacity. That's one of the inclusion criteria in the published studies. But as we all know, capacity assessments in anorexia can be hugely complex. And of course, if DBS is successful in anorexia nervosa, what that tends to mean in terms of clinical outcomes is that you observe an increase in BMI after the application of stimulation. We're still trying to get an understanding of what precisely that's doing to the patient's evaluative structure, if you like. Again, a lot is going to depend here on the model of anorexia you have, and particularly where you're stimulating. So the Lipsman paper that I provided a screenshot of, they targeted an area of the brain called the subcallosal cingulate, partly because they viewed anorexia nervosa amongst their recipients as a disease of emotional dysregulation, essentially. In contrast, the group in Oxford, amongst others, have targeted the nucleus accumbens, which is an area implicated in reward processing. And they were, as their published protocol suggests, viewing anorexia as, in some cases, a kind of compulsive disorder. And so one of those different disease models, you might think that anorexia is having quite different implications for, if you like, the authenticity of the patient's values and which sort of wishes we should be respecting. Because if anorexia is this kind of external compulsion on someone, then we might think by taking away the disorder in some sense, or taking away the influence of the disorder, we're allowing the person to become themselves again. And that's what we see in the patient interview studies. When people say, I'm a new person following DBS, when they're asked to expand upon that, what they're saying is, I feel like I'm me again. And that's what Sneaker DeHaan's big finding from that paper was really. So I know that's not a good answer because it gets hugely complex, but I think a lot's going to depend on, like I said, the model of disease you're attempting to treat and the kind of job that you're hoping stimulation is going to do. But it's, we could do a whole nother seminar on the answer to that question. I think it's hugely complex.
Oh, is that a finger, Alex?
Yeah, it is.
Yes,
Yeah,
we'll do fingers.
I was also going to ask about transformative experience, something they just like stop talking about it. But in a way that actually ties nicely into that case, because I mean the way that Alston asked you about it was as if, well, we can ask the person when it's manic or when it's not manic, but you take seriously that it is a transformative experience. There's a sort of puzzle. I mean, puzzle there, right?
Yeah.
Because you're not supposed to be able to go back. And with this guy in particular, you actually gave it as an example of how impressive reversibility could be. What you might think is actually an illustration of the irreversibility, right? Because you might think, well, if you'd asked him before trying it, well, we can give you this treatment, but you're going to have to be put in an institution. Most of I absolutely don't want to do that. Well, having experienced it, his values have now been transformed, and now he is willing to make that trade-off. And having changed his values in that way is something that's irreversible.
Yeah.
Right?
Yeah.
It might be an illustration, and a thing that's importantly not reversible rather than reversible. I mean, it's both.
Yeah, no, I absolutely take that point, and reiterate, it gets hugely complex because then you essentially have to make a call about which values are authentic to the person, right? And you might want to talk about two different individuals almost, and should you be protecting one rather than the other? My view on that is I perhaps don't buy the full Laurie Paul transformative experience angle. So I think you can make somewhat rational decisions even in the absence of some forms of epistemic access, and even if your values change. That is a bit of a long story, I suppose, but I think what's really important for that to be possible is the intelligibility of that change in values. So if you're directly inducing changes via electrical stimulation to the brain, that's of course going to be unintelligible to you. But that doesn't appear to be what is really happening when we look at the ways in which people are recovering from conditions following DBS. So again, if you're interested in this, I absolutely recommend Sneaker DeHaan's work, because she not only does really fantastic interviews with these patients, she goes into a lot of the philosophy about the nature of identity and agency, which is directly relevant to these questions. As I mentioned it in response to the earlier question as well, what we see in these interview studies is the idea that DBS isn't changing my values necessarily. It's just lifting away something that was stopping me from realizing the values that I had all along. And in that case, I don't think DBS is necessarily a truly transformative experience. If you're going to really pin me down and say, let's just suppose it really, really was, then yeah, it's a hugely difficult area. And I don't think anyone's got a good answer to it. Maybe if we really buy the story that you can't make autonomous decisions about transformative experiences, then we have to adopt an either paternalistic line or a non-maleficence line. That would be very difficult for people wanting to get pregnant. So I think we've got to find a different way. So thanks.
Sorry, we have another finger on this, and then we will have time to fit in your hands. So Elliot Porter, please.
Hi, thanks. Can you hear me?
Yeah.
Thanks. So I just wanted to sort of two related thoughts to throw in here that might be relevant. One is that if we don't have a sort of authenticity view of autonomy, then I think we get away with quite a lot more of the change. It's less important that this is, these are the proper values that are in question rather than are these imposed values. And we then want a more detailed story about how we get ownership over the values. What springs to mind here with me is the intelligibility story you told might run into a bit of difficulty if what we're concerned about is the way in which moods make us just, if we think moods change our values, so if mania and depression change my values, it's because maybe for a kind of existential feelings type reason, I'm now just looking at the world and different kinds of consideration are jumping out to me as relevant, at which point there's no way in which this view is separable from any of the other views. None of them are more authentically mine, at which point we're stuck with the ownership question, at which point it might be unclear whether deep brain stimulation or any other kind of intervention creates this problem. It's maybe more about how do we take responsibility or take ownership of the values we wind up having. And if we can wind up with sort of values that are more pro-social or can just serve our well-being better in other ways, it might be useful that they change so that we have better values available to take ownership of. And that's a different way of respecting authenticity. And it allows for, or it legitimates a degree of, I don't want to call it paternalism, but kind of being pushed in the right direction if we have this kind of autonomy as sort of responding to the actual reasons view.
Yeah, no, that's some really nice insights. The first point about the initial point about transformative experience, I suppose the issue would be, so you mentioned that if you don't have an authenticity condition on autonomy, then some of these problems go away. I think that's true to some degree, but then what you're going to have is essentially two people making autonomous choices, which are in stark contrast to each other potentially. And then the question is going to be, well, which person's choice should we respect, right? So it's in some ways out of the frying pan into the fire, I suppose. But the broader point I think about the role that authenticity can play in taking ownership of values in autonomy, I think is right. So the idea about intelligibility, I wasn't necessarily suggesting that these changes have to be in a way rationally intelligible. So I view intelligibility as incorporating a much broader range of psychological features. So your emotional state can make things intelligible to you. It's a mode of experiencing change, if you like. What I wanted to get at when talking about intelligibility is to get away from this idea that deep brain stimulation is just a way of, really fundamentally physically changing your brain and making you do something that you never would have done before. That's maybe a way in which I think people working in philosophy and neuroethics sometimes speak about the intervention like that. But when you look at the clinical data and the patient interviews, it's a much more nuanced picture. I agree with you. The really important question is, how do we make sense of taking ownership of values in authenticity arrangements and autonomy? And that's hugely complex in psychiatry, generally due to the ego-syntonic nature of a lot of these disorders. And I think DBS is just hugely complicating that question, because it's bringing about changes that patients can sometimes welcome, but also changes that they can feel deeply alienated from. So yeah, I don't pretend to have answered that question, and it's one that is still today really motivating the field of neuroethics. But yeah, I thought there were some great insights. Thank you.
I think a lot of people highlighted that difficulty when talking about reversibility. But one of the things that struck me was that there are always these kind of dualistic assumptions built into that. If you think about, for example, if you're in the psychiatric ward, a really horrible traumatic experience, right? That would be something you would consider to be quite a irreversible permanent experience. That actually, because it's quite hard for us to conceptualize that as a kind of treatment or non-treatment, we tend to fixate on, again, the kind of the way that those things happen rather than the actual outcome. And so I wonder whether the kind of attention on reversibility is more to do with the sort of dramatic nature of the treatment rather than actually these kind of underlying features that, it sort of almost seems to rest on the fact that we see these, we don't appreciate the way in which all of these other things are very, very reversible.
Yeah, no, that's a good observation. I think, again, a bit of detail I didn't manage to get into today was, I think reversibility is maybe a little more complex than the manner in which it's used in ethics, because typically reversibility is used simply to track claims about permanence or whether a change is permanent or not, right? So if a change isn't permanent, then we say it's reversible. Now that's right, but sometimes we're using the terminology of reversibility. We want to capture something deeper, which is, in some cases, we can control whether the change occurs or not. And that's the really crucial thing about DBS, right? So it's not just that the effects can be temporary, it's that you can control whether or not they occur. And that can be, as we saw in the Leachin's case, that can be really important. So if that person had undergone a surgery which led them to develop a manic state, suppose we said to them, okay, don't worry, in 10 years, this is going to abate, and then we can decide whether or not to do the surgery again. That would be much worse than being able to click a button and say, okay, what do you want to do? Notwithstanding all the difficulties in determining which should be respected in some of those cases. But yeah, no, I take the point. I've tried to do a bit of work trying to tease out some of the nuances of reversibility in DBS, but I think the more I worked on it, looking elsewhere in medicine, not to mention definitions of death, reversibility is a much abused term in medicine, I think, and it's something I'm interested in.
I think with that, I should not take, given that we are not take another question. We're 2 minutes before 7. But I want to thank Dr. Pugh for a great talk and, remarkable resilience and flexibility in the light of our changed schedule, and the audience for a great discussion. So thank you very much.
Thanks so much.